of doctors from Budwan as a guest speaker with over more than 24 years of experience in the field. Sir is known to provide exceptional care to his patients. We are grateful for his dedication and to improving liver health and educating people about this important topic. Without further delay, I would like to invite Dr. Soumik to share his valuable insight on management of NAFLD and NASH. Over to you, sir.
Thank you, Ketuki. Now I'm directly going to the topic. Today's topic is on NFLD and NASH. Actually, this is a global problem and prevalence is 25% just because of our lifestyle, our food habit change, and our some other environmental changes. So in India, it is even higher than the prevalence of the global one. It's 38.6%. And in India, it is more in South India than North India or other parts of India, just because I think it's a saturated fatty acid containing oil intake of South India. So NFLD, whenever it is now changed to the name of MSLD, but NFLD still we use just because it is directly related to the liver fat consumption. Whenever fatty liver disease comes, it is over more than 5% of the cells will contain uh, the liver fat into its liver parenchymal cells. So whenever it is more than 5% of the steatosis in the hepatocytes, it is called NFLD. And it can be divided in according to the stage of NFLD. Mild one is just the pure steatosis and there may be mild lobular inflammation, not that much prominent in the liver biopsy. So it is non-alcoholic fatty liver only. When there is inflammatory changes, then it becomes NASH, that is non-alcoholic steatohepatitis. And thereafter, it comes to the fibrosis, and that can lead to the hepatocellular carcinoma also. So early fibrosis to fibrotic changes to cirrhosis, all this starts with the accumulation of the fat, that is the steatosis, more than 5% in the hepatocytes. Why it happens? Now, the two heat theory is very much popular in case of this occurrence of this NFLD. It is if there is no insult to the liver, it is nothing, liver will be healthy. Whenever there is the steatosis, the first hit comes to the liver, and then it leads to the inflammation of the liver. Then microbiome gets activated, it secretes the fibrotic material and fibrosis occurs, replacing the hepatocytes. And finally, there is endoplasmic reticular stress, and this stress give more damage to the liver, leading to more fibrosis, leading to cirrhosis. So what happens in the molecular level, whenever there is the high fat content in the liver, maybe from the dietary simple carbohydrate like fructose, sucrose, or glucose, or direct adipose tissue increased, or intake of more fat in daily regular food habit, that can lead to more circulating free fatty acid into our body, and that free fatty acid leads to the lipotoxic lipids, and these lipotoxic lipids give stress from the oxidative part, that is the oxidant stress, that may be endoplasmic reticular stress, or along with that there may be some inflammatory activities cascades that leads to inflammation, hepatocyte stress or death, fibrogenesis. uh, there may be some genomic DNA damage also. So all cascades come accordingly. Why happens this fatty acid liver disease? There is microvascular steatosis. In case of long non-alcoholic fatty liver disease, the obesity, the diabetes mellitus, these are most important two causation. Other causations are starting from starvation to parenteral nutrition to medications, and some genetic disorders like Ray's syndrome, so maybe the HELP syndrome, and inborn error of metabolism may be there. But obesity is the first and highest cause commonly found in NFLD patients, along followed by the high triglyceride level. Some cytotoxic drugs also do harm to the liver, like azathioprine, steroids, tamoxifen, and some calcium channel blockers also. Along with that, some surgical procedures like gastric bypass, jejunal bypass, some other diseases like inflammatory bowel disease, severe anemia, and total parenteral nutrition. These may lead to the non-alcoholic fatty liver disease and its consequences. Some intestinal bacterial overgrowth, SIBO, can lead to the NASH just because of their increased endogenous ethanol production and release of the LPS. So when NFALD occurs in non-diabetic patients, the cascade is very slow and the percentage of leading to NASH or cirrhosis or hepatocellular carcinoma is lower, but not negligible. But if diabetes is there, the all the percentage becomes double. So diabetes can aggravate this thing, and diabetes can, along with the causation, thus consequences with diabetes are very poor and grave. So this leads to higher rate of the carcinoma and mortality also. So diabetes, whenever associated with fatty liver disease, must be treated. NFLD is closely associated with this our metabolic disorder related things, including diabetes and this metabolic syndrome that is coming to the discussion always with the non-alcoholic fatty liver disease that is along with diabetes, hypertriglyceridemia, low HDL, and increased waist circumference and high blood pressure. All these complex leads to metabolic syndrome. And these metabolic syndrome are now very common and it correlates with NFLD and its poor prognosis. So how to detect? There is almost always, you keep in mind that symptoms will not be there. There will be some symptom in case of 50% patients and vague symptoms, even lesser than that in case of the initial stage of non-alcoholic fatty liver disease. And the signs of hepatomegaly is not always a constant feature. Uncommon symptoms come with vague abdominal pain, mainly in the right upper quadrant, fatigue, malaise. Signs like splenomegaly, spider angiomas, palmar erythema, and ascites are the lead consequences. And there are the chances of elevated liver enzymes, ALT and AST. Usually, ALT is to AST is greater than 1, but it is not a constant feature. So, it is not a reliable and 100% gold standard of diagnosis of this fatty liver disease. Alkaline phosphatase may be normal or slightly elevated. Bilirubin is almost always normal in case of the earlier stage, and elevated serum ferritin is when the patient leads to cirrhosis. So initial evaluation always considered with the, whenever you inquire the patient for diagnosis of this NFALD, you have to inquire about the alcohol intake, the personal and family history of diabetes, hypertension, cardiovascular disease. The BMI should be considered. Any hepatitis, viral hepatitis should be evaluated. The patient's history of associated drugs are there or not. Other things like this glycosylated hemoglobin is a very important marker. Complete blood count, especially the platelet count. I'm coming later to the platelet count and its significance. The serum total HDL, cholesterol, triglyceride, uric acid, ultrasonography, if suspected raised liver in fatty liver, and if there is any suspicion of non-alcoholic fatty liver, go for the ultrasonography. And extended evaluation when the advanced stage is there, uh, consider for the ferritin transferrin saturation test for the celiac and thyroid disease, PCOD, liver diseases from genetic side should be evaluated in history. For fatty liver, thanks to the radiologists, they are over enthusiastic for diagnosing the fatty liver. So first fatty liver diagnosis without having any symptom comes from the radiologist's reference, because they diagnose grade 1, grade 2, grade 3 fatty liver by if grade 1, that is mild, the first notification comes from the radiologist that increased echogenicity of the liver in comparison to spleen and right kidney. For grade 2, the blurring of the intravascular structure, that is periportal structures, are blurred. Grade 3, when deep attenuation of the ultrasound signals are there and diaphragm cannot be discerned from the posterior surface of the liver, that mimics that it is severe, that is grade 3 fatty liver disease by abdominal ultrasonography. So when platelet is a very important thing, as because portal hypertension is almost always related to platelet count deterioration. So there are many scoring systems that like APRI, FIB4, NFS, and BRD score. But for simple, clinical, reliable scoring system, that is FIB4 scoring system, that can give you some hints that whether there is the fibrosis, and the severity of the fibrosis can be assessed by this FIB4, which is considered by this age, the AST, divided by the platelet count and the ALT result. So this you can do easily from your blood test report at your clinic. But the main thing that is now considered along with the FIB4 scoring, that is liver stiffness direct measurement by the ultrasonography, we commonly call it the fibroscan. Basically, it is the liver stiffness measurement. And this liver stiffness measurement, when becomes higher, that is 8.2 kPa or higher, then this NFALD diagnosis along with the FIB4 scoring can be established. Though the actual gold standard of the diagnosis is liver biopsy, but liver biopsy should not be done as a routine one, as it is a invasive procedure with some complications also. So USG, serum transaminase, FIB4 scoring, and the liver stiffness measurement, all these are considered for diagnosis of the NFLD cases. And INSL recommendations are also there supporting these tests. So even gold standard of diagnosis is liver biopsy. Still, it should be avoided until and unless you find that there is the metabolic syndrome, insulin resistance there, metabolic syndrome is there, these risks are there. There are persistent potential signs of cirrhosis or abnormal liver enzyme for more than 6 months and not responding to your common lifestyle modulation along with medication. So then you can go for liver biopsy. So for diagnosis, I already discussed. First, the ultrasonography gives us the hints that there may be some non-alcoholic fatty liver disease. Then the cascades come, as I discussed. But this NFALD, is very much important, not because of the liver, but first, the risk of cardiovascular disease and CKD. These cardiovascular disease and CKD can lead to NFLD, and this NFLD as a vicious cycle can lead to more grave consequences of cardiovascular disease and chronic kidney disease. As because in case of the liver stiffness, there is a higher chance of the cardiac load to the heart. And in case of the CKD, there is again the chance of higher blood pressure, as well as the decreased renal excretion with the our excretory products accumulation into the body, and more inflammation, more damage to the liver can occur. So this vicious cycle, if can be treated from the NFLD in the initial stage, then along with that, cardiovascular disease and the chronic kidney disease can be treated simultaneously. You will get a better result from the therapeutic point of view. As I already discussed, it is divided into the low risk, intermediate risk, and higher risk by the FIB4 scoring and liver stiffness measurement. If low risk, then the FIB4 scoring is lesser than 1.3, and the liver stiffness measurement is less than 8 kPa. Intermediate cases, the FIB4 scoring does not cross the 2.67, and liver stiffness measurement is within 8 to 12 kPa. But if it crosses, then the high risks occur, and there may be definitely you will find the more liver fibrosis, and the chance of finding cirrhosis and chronic liver disease are more. For management of the NFALD, you have two ways. One is control of the risk factor, and second is the pharmacotherapy. For that, integratedly, you have to change your lifestyle. You have to modify your comorbidities, and even needed, you can go for bariatric surgery to reduce the body fat or simple carbohydrate intake, and to reduce the body weight also. For lifestyle modification, you have to give stress upon the exercise, diet modification, and weight reduction. For comorbidity management, commonly we find the diabetes, the hyperlipidemia, and withdrawal of offending drugs. One thing I must mention, in our region, vitamin D deficiency along with hypothyroidism are other two comorbidities that is associated with NFLD. So for lifestyle modification, energy restrictions should not be very stringent, and this should not be within a short time with having more restriction to the calorie. It should be done gradually, stepwise, with 500 to 1000 per day kilocalorie restriction, and that can be more reduced by every 1 to 2 weeks according to the weight of the patient. And if gradual energy restriction is not done, the rapid restriction of starvation can lead to NFLT by itself. The fructose intake, it definitely you should avoid. There are some controversial things, that is coffee consumption, but remember, 3 cups of strong coffee every day for 6 months can give you some results with improving of this liver stiffness measurement score. So it should not be routinely considered for the patients of CKD or this cardiovascular disease. The macronutrient should be with low to moderate fat, moderate to high carbohydrate, that is complex carbohydrate, not simple carbohydrate, and low ketogenic carbohydrate should be given. And alcohol intake for our region should be totally abstinence from alcohol And in European countries, they say that 30 gram for male and 20 gram for women is sufficient. And physical exercise, the most important lifestyle modulation technique after this energy restriction, that is 150 to 200 minute per week moderate intensity exercise in divided 3 to 5 sessions per week is a must for almost all the patients of NFLD is needed. For pharmacotherapy, you have to give stress upon the steatohepatitis, the bridging fibrosis if there. If NFLD has the other risk like the higher age group hypertension, the insulin resistance, and the uncontrolled diabetes. So if these are there, or in some cases, even after having the lifestyle modulation, there is no improvement of the mild stage of NFLD, you can think of the pharmacotherapy. But no drug is yet the gold standard of therapy from the pharmacological side for NFLD treatment. Still, some insulin sensitizers have given much better results. So PPAR gamma agonist, that is pioglitazone, has been considered better than the placebo. And this pioglitazone, that is the hypoglycemic agent uh, in therapy of the diabetes mellitus, that was first tried after this vitamin E therapy. And what are the drawbacks? I'm coming later on. Uh, there are vitamin E therapy, the pioglitazone, all these came. And but vitamin E directly helps for improving the steatosis, preventing the fibrosis and the inflammatory cascades. So these are helpful for NFLD treatment. But remember, though the statins and the fibrates, all these can directly do harm to the liver and the mm, pancreatic tissue. Still, if there is dyslipidemia and higher rate of the hyperlipidemia is there, you must treat the case with the lipid lowering agents. Mainly, you have to give statin, avoiding the uh, fibrates first. And among the statin, it's atorvastatin is always preferred over rosuvastatin, though rosuvastatin controls triglyceridemia uh, more in better way, and the percentage of the triglycerides get more reduced than atorvastatin. Still, rosuvastatin should not be used as a routine, but you must try with atorvastatin first. Some surgeries are there. Now we endoscopists do some endosurgeries like this balloon, gastric balloon, which can reduce the total gastric containing area and making the gastric capacity lower, having occupying the space in the stomach. So these can be done, and now the reversible endosuturing that is done along the greater curvature of the stomach, sewing it, making the stomach in a reduced pipe-like fashion. And this also can reduce the stomach volume. So both of these procedures are reversible and can be safely practiced. When pharmacological management comes, first came the insulin sensitizer and antioxidant, that is vitamin E. But later, obeticholic acid, semaglutide, metformin, ursodeoxycholic acid, statin, silimarin, all these came to the market, and the head-on trials, meta-analysis, all these give us actual scenario when it says that these are not very good and very directly acting pharmacological agents, then the next one which came to the market, that is saroglitazone. Vitamin E is a seesaw vitamin. So vitamin E is to be given for 800 milligram per day in two divided doses for 2 years. That is very difficult to tolerate. Patient will have nausea, vomiting, anorexia, and there may be some grave consequences like hemorrhagic stroke and the uterine cancer also, and prostatic cancer also. Then pioglitazar can be given for 2 years and it works. But pioglitazone has a drawback, that is, it works only with PPAR gamma, not PPAR alpha. But saroglitazone when came, it is 1 year, well tolerated, very simple. It is a very good insulin sensitizer as well as it works on PPAR alpha and gamma. So these alpha and gamma action uh, conjointly gives us most uh, desirable result for uh, having relief of this non-alcoholic fatty liver disease from lowering the fatty acid oxidation, increasing the good fatty acid HDL, as well as it sensitizes the insulin receptors and glucose uptake and metabolism is more in case of saroglitazar. That's why saroglitazar is now a preferred drug in India. So everywhere, whenever there was the trial, it was shown that it is a very good insulin sensitive index, having good result for NFLD, along, especially along with the insulin resistance and diabetes mellitus cases. But in case of the non-diabetic patients, it is also good as because there is no chance of hypoglycemia for saroglitazar. Uh, that agent can control the triglyceride as well as the glucose as well as the inflammatory cascade is lowered down. So when pioglitazone and saroglitazar is compared, then again we found that 4 milligram saroglitazar per day in comparison to 2 milligram saroglitazar or 30 milligram pioglitazone is better in case of serum triglyceride level control as well as the improvement of liver stiffness measurement. So when saroglitazar is the agent, then it controls the triglyceride. Again, I am repeating, it controls the triglyceride. It is controls the non-HDL. It hires the HDL. It controls the glycosylated hemoglobin level as well as the liver enzymes are lowered down. That is, the liver gets relief from the inflammatory changes into its liver parenchyma. Again, when the NFLD activity score is considered, then again pioglitazar in with respect to the fibrosis in 1 year continuous therapy gives better result. So whenever you get some patients with persistent elevated liver enzymes or the risk factors of along with the non-alcoholic fatty liver diseases, you first exclude the other liver disease, go for diet and exercise and other metabolic syndrome treatment first. These are constant features. Then, if there is any abnormality in the liver enzymes, even after 6 months of your therapy to metabolic syndrome and giving diet and exercise modification, then if you think you can go for liver biopsy or you can again go for the management of the comorbidities, lifestyle modification, and you can continue the therapy of saroglitazar up to 1 year. Then again, you assess if there is no improvement, go for liver biopsy. If more chances of fibrosis or very quickly in 6 weeks repeat of this liver stiffness measurement gives you higher score, you can go for liver biopsy, but not a routine practice should be there with the liver biopsy. So thank you for this treatment algorithm of the non-alcoholic fatty liver disease. Sorry, as because my slides notice that it is suddenly suddenly stopped. But now again for discussion, there are some other agents are coming to the market like semaglutide again and oral hypoglycemic. And there are some other agents like thyroid hormone receptor agonist, uh, again that are coming to the market. But still, if you consider about the treatment of the non-alcoholic fatty liver disease, there is always uh, you should go first for the lifestyle modification, go for the treatment of the comorbidities, then you think of the pharmacotherapy. And in case of the other agents like silimarin, like ursodeoxycholic acid and silimarin both are having the property of antioxidant, anti-inflammatory agent one for the liver. They can give you some results, but whenever till date, if you think of, you can confidently give saroglitazar for 1 year without having much side effect and without having any hypoglycemia at any point of time therapy with this saroglitazar agent. So thank you for listening the entire slides, and I'm sorry for I suddenly stopped with my other slides. I think I cut it down just because of some time constraint someday. So that I presented to you. So if there is any question, kindly come to the question answer session. I think that will suffice your queries.
Yes, sir. Thank you so much, sir. So now we will move towards questioning part. So what kind of diet is recommended for NFLD patient?
In case of NFLD patients, you always have to consider first the total calorie part that should not be cut down to less than 1,000 kilocalorie per day, and that should be done for more obese patient. That should be done 1,000 kilocalorie per day reduction with having 2 weeks of gap. And in case of lean patients, you have to cut down the total calorie per day intake 500 kilocalorie per day gradually to take it to 1,500 kilocalorie per day for obese patient and 1,000 kilocalorie per day for non-obese patient. Women can have little bit lesser than the men um, as a counterpart of the having other standard of other parameters, but still that should not be less than 1,000 kilocalorie. You must avoid the high glycemic index food. You should go for low glycemic index food with having more fiber content so that it can absorb mechanically and take out the excess fat or carbohydrate or whatever you ingest in your diet. And the good quality of oil or polyunsaturated fatty acid containing high poly, so these polyunsaturated fatty acid should be higher in your diet, and the whatever the oil is, always remember you should not cross the limit of 20 grams per day oil intake into your 24 hours diet.
All right, sir. So now, sir, on behalf of Nash 24 by 7, I extend my sincere thanks to Dr. Shomik for his enlightening and engaging talk today. I also want to express my appreciation to our audience for their participation. Please stay connected with Nash 24 by 7 on Facebook for upcoming updates and information. Take care, stay well. Thank you so much, sir, for joining us today. Thank you.